All right, what's up, everybody? Recurrent pregnancy loss, Kennenomortag, it's the light board. You know what it is. This is part 2 of the workup part of recurrent pregnancy loss. This is where we start to get into less well-studied areas of the workup, but let's talk about them. The first, we talked about genetics, anatomy, hormones, autoimmune disease. There's pretty good consensus around those being the central workup for recurrent pregnancy loss. Infection is looking for infection is a less controversial area as well. The idea here is that there might, if you have recurrent losses, is it possible that you have some underlying chronic inflammation? So the workup there usually involves an endometrial biopsy. So talk to your doctor about the role of that, and sometimes even empiric antibiotic treatment for a week. For 2 weeks. If there is some underlying bacteria, mycoplasma is thought to be a common one. There are others, then we would empirically treat. But a lot of times people will do an endometrial biopsy, which is a sampling of the endometrial lining to see if there is some chronic inflammation or chronic infection, usually some bacteria. Many times it's abnormal, or it's normal, but still part of the workup. Again, talk to your doctor about the role of this type of testing. You'll hear a lot of people when they talk about recurrent pregnancy loss talk about progesterone support. This goes back to the idea that after you ovulate, the ovary makes progesterone, and that progesterone helps support the implantation. You have an embryo that implants, and that embryo makes HCG, and that HCG supports a structure called the corpus luteum that makes progesterone. So if that progesterone is not being made, then this lining can't, or the embryo can't continue to grow. So one of the thoughts here is that if you give patients progesterone, then maybe you can reduce their chances of having a subsequent loss. We'll talk about that in the next section of the talk. But basically, there isn't any testing to do. People will talk about checking progesterone levels, and should the progesterone level be above a certain level. There are some timing nuances to that, and they're very individualized. So I will not really go into a lot there, other than to mention it may be a role for progesterone support, and we'll talk about that in the next video. Another thing you'll see a lot of is a thrombophilia workup. So the idea that maybe I'm having these losses because I'm throwing some minute blood clot because I have some propensity for having a blood clot, and I'm just creating micro blood clots that are preventing the pregnancy from growing. The likelihood of let me just say a couple things about this. The American College of OBGYNs, the American Society of Reproductive Medicine, do not recommend thrombophilia workups in patients with recurrent pregnancy loss. There was a time, I think 25 years ago, when it was okay, or it was done. But the evidence has shown that these workups don't yield any actionable intervention that then goes on to reduce risk. So the workup for these types of thrombophilias, and I'll talk about them in a second, is not recommended. However, some of them, there might be a role if, and this is a big if the patient has a history of a blood clot in their leg or their lung. Then there might, and they also have recurrent pregnancy loss, then there might be a role for doing this testing. And these are, what I'm squaring here are some of the tests that might be done in those cases. Again, if a patient has recurrent pregnancy loss and a personal history or a close family member with a blood clot in the leg or the lung, then there might be a role for doing some of this thrombophilia workup. And again, I defer to your OBGYNs, talk to your reproductive endocrinologist about the role of these testing, because this is there is still a lot of, in my view, there isn't much controversy about the role of these tests. I don't think they're indicated in just patients with recurrent pregnancy loss, but it's still done a lot. So again, I want to make it clear that you should talk to your physician about what's best for you and what the role of these tests are. MTHFR gets a special call out. This is also thought to be more speculative in the risk of thrombophilia. The idea here is that MTHFR disrupts A mutation in this enzyme will cause an increase in homocysteine levels, and homocysteine levels have been associated with some cardiac related or vascular related thrombotic events. So maybe it's also causing problems with recurrent pregnancy loss. So let's start checking MTHFR levels. I'm not enthusiastic about this test because it hasn't been demonstrated to be a cause of recurrent pregnancy loss. Some people will talk about folate and folic acid supplementation in patients with MTHFR mutations. Again, I would recommend talking to your reproductive endocrinologist, your OBGYN. This is not something we can, it's nuanced, and it's important to have a more structured conversation with a physician than to watch a 6-minute Instagram TV video on this topic. But in general, I don't recommend this test. I have patients where it's done, and that's okay. We talk about it, and we talk about what we need to do moving forward, if anything, with supplementation. So this is the second part of the workup where there's a little more controversy. Again, infection, not much controversy. There is a role for it. The progesterone, we'll talk about that in the next section when we talk about the approach to treatment. The thrombophilia is highly controversial in that there are still a lot of folks who still do an empiric workup on thrombophilias in patients with recurrent pregnancy loss, in spite of recommendations recommending against the need for that testing. But again, remember, if the patient has had if the patient has prior blood clot in their leg or their lung, then maybe there is a role for this thrombophilia testing. The MTHFR, I'm not enthusiastic. The data is not suggestive that this is a part of the routine recurrent pregnancy loss workup. That being said, there's a cottage industry of people who talk about the value of the test, and I have patients who have it and that have the testing done, and they come see me and we talk about what the test means in their treatment going forward. And I think that's what's most important, is just being honest and transparent with people. So with that being said, that ends the part 2 of the workup on recurrent pregnancy loss. The next part is going to be talking about the approach to treatment. So we'll see you then.